Good morning. We have with us Dr. Gerald Schultz, Professor Kumaramanickavel, and Dr. Rajkumar. The slides are ready. Can I have that schedule, Dr. Rajkumar? Dr. Raj, can I? Yes. Can I have my slides? And Gerald? Jerry, can you come here? So when I'm going to give the talk, you can be. So Dr. Gerald Schultz is an ophthalmologist who is coming to All India Ophthalmic Society from 80s, and his interest is in, apart from the anterior segment, he also interested in ocular genetics, and he's a very old friend. Thank you, Jerry, for all the way from US every year, year after year. And they welcome to the ophthalmic genetics. How should a clinician interpret a genetic result to help the patient? So I'll give the first talk on retinal genetic eye diseases, and next will be followed by Professor Kumaramanickavel. And I have 2 other sessions to go. Jerry, I request you to, after my talk, and Professor Kumar to continue the. Good morning. So, welcome to this course on ocular genetics and retinal genetic eye diseases. So, history of gene therapy. In the 1940s, nucleic acids were identified as the carriers of genetic information. In the 1960s, virus-based methods for delivering therapeutic genes to patients were developed. In the 1970s came recombinant DNA technology, and first approved gene therapy clinical trial in 1990 for children with severe combined immunodeficiency. Why eye is suitable for gene therapy? The eye is partially shielded from the immune system, reducing the possibility of an immune attack on the virus used to introduce the genes. The eye is also relatively easy to access, allowing surgeons to inject the virus near to the cells in which the gene is needed, because more than 200 genes are associated with retinal disorders. The opportunities for genetic correction is enormous. How retinal gene therapy works? The vertebral neural retina contains many different types of cells like retinal ganglion cells, rod and cone photoreceptors. Rod and cone photoreceptors, etc. In retinal gene therapy, adeno-associated virus enters these various types of cells and expresses the DNA sequence of intended therapeutic value. So the AAV is the one which is used, and retina cells are non-dividing, therefore AAV persists and provide therapeutic expression of DNA sequence over a long time period. In 2008, 3 independent research groups reported that patients with the rare genetic retinal disease, Leber's congenital amaurosis, had been successfully treated using gene therapy with AAV. In all 3 studies on AAV vectors was used to deliver a functional copy of the RPE65 gene, which restored vision in children suffering from LCA. And AAV as a vector for gene therapy, the great advantage in using AAV for the gene therapy is that it possesses minimal immune responses and mediates long-term transgene expression in a variety of retinal cell types. Initial studies have used AAV serotype 2. Nowadays, new variants of AAV are being developed to increase the efficiency of gene transfer process. After intravitreal injection, only AAV serotypes 2 and 8 were capable of transducing retinal ganglion cells. Administration of gene therapy to retina. Generally, AAV is administered by two routes, intravitreal or subretinal. In the intravitreal route, targeting retinal ganglion cells and a few Muller glial cells, AAV is injected in the vitreous humor of the eye. In the subretinal route, targeting photoreceptors and RPE cells, AAV is injected underneath the retina. And these different routes are necessary for different cells because the inner limiting membrane and the various retinal layers act as a physical barriers for the delivery of drugs and vectors to the deeper retinal layers. Generally, subretinal AEV is more efficient than the intravitreal route because the subretinal route may be subject to a greater degree of immune privilege compared to the intravitreal route. And that's my interest as a vitreoretinal surgeon because we need a vitreoretinal surgeon to do the gene therapy, that too in the subretinal space. And regulation, control of transferred gene. Since continuous strong expression of newly transferred gene is sometimes harmful for long-term retinal health, it is necessary that such gene expression should be regulated by some means. One way is using a promoter system in ABV vectors which can be regulated externally. One example is tetracycline-induced expression system, which uses a silencer or transactivator AAV2 vector and a separate inducible doxycycline response coach-injection. Applications of the gene therapy in different eye conditions. Retinal gene therapy holds great promise in treating different forms of non-inherited and inherited blindness. Let's have a look at eye diseases for which retinal gene therapy holds promise. Mitochondrial Leber optic neuropathy. It's a retinal disease of ganglion cells that leads to blindness in young adults. 1G to A transition in mitochondrial DNA at position 11778 in the gene encoding subunit 4 of NADH dehydrogenase ND4 leads to a position 340 Arginine to histidine substitution that is responsible for approximately half of the LHON cases. Studies showed that allotopic mitochondrial gene delivery can be effective and safe mode of therapy for LHON. And Leber hereditary optic neuropathy, the maternal mitochondrial DNA mutation presents typically in males, third decade, occasionally in females, any age, initially unilateral visual loss, fellow eye involved within 2 months, bilateral optic atrophy, signs disc hyperemia and dilated capillaries, telangiectatic microangiopathy, vascular tortuosity, swelling of peripapillary nerve fiber layer, subsequent bilateral optic atrophy. And Leber's congenital amaurosis in 2008, 3 groups reported positive results of clinical trials using adeno-associated virus for Leber's congenital amaurosis. In these studies on AE vector encoding the RP65 genes were delivered via subretinal injection, and that's I think Dr. Gerald Schultz will be talking about it, which is the most expensive treatment in the world in any medical history so far. It's about 5 crore rupees or 4.5 lakh dollars. Across 3 trials, no serious adverse events were observed. Furthermore, patients in all 3 studies showed improvement in their visual function and continuing to do well after more than 1.5 years. And the other condition is wet AMD, which is treated with frequent injections of recombinant protein into the eyeball. Therefore, scientists are working on long-term disease management by a single dose of drug, and which is will be the dream project. And here you see a patient with the ARMD with a submacular hemorrhage. The other condition is choroideremia. One clinical trial reported in January 2014 used subretinal AAV to restore the RPE gene in affected patients, and initial research stated that all patients had better vision. And that's a fundus photograph of a choroideremia. And color blindness, which is so far, I think there was no treatment or nothing could be treated, but at least there is some ray of hope and there's some light in the end of the tunnel. Recent research has found that AAV can successfully restore color vision to treat color blindness in adult monkeys. And juvenile retinoschisis, it is an X-linked recessive degenerative disease of the central macula and affects the nerve tissue in the eye. And the disease is caused by mutation in the RSI gene encoding the protein retinoschisin, important for maintaining the synaptic integrity of the retina. The AAV5 vector containing the wild-type human RSIC DNA driven by a mouse opsin promoter showed long-term retinal function and structural recovery and improvement in the retinal structure reliability. And this is the X-linked juvenile retinoschisis with a foveal cyst. And the other condition is retinitis pigmentosa. It is an inherited disease which leads to progressive night blindness and loss of peripheral vision as a result of photoreceptor cell death. And most people who suffer from RP are born with dysfunctional rod cells, so they are effectively blind at night time, since these are the cells responsible for vision in low levels of light. After that, cone cells death occurs, which are responsible for color vision and acuity. Loss of cones leads to full blindness in children. And that's a fundus photograph of a RP patient. And the disease can be inherited as an autosomal recessive, autosomal dominant, or X-linked type. And unfortunately, India has the highest number of RP because of all the forms of inheritance, as well as there's a consanguineous marriage in India, and which is still there going in the families. And when mutations occur in the rhodopsin, the directional protein movement is affected because the mutations can affect protein folding, stability, and intracellular trafficking. Gene therapy to RP is introducing AAV delivered ribosomes designed to target and destroy a mutant mRNA. And this is the RDH11 syndrome with the defective genes RDH11. And another mutation in the rhodopsin structural protein, specifically peripherin 2, it can lead to recessive RP and macular degeneration in humans. And if the mutation RP is unknown, then gene replacement therapy cannot be administered accurately. And the other is the retinal degeneration. It's an inherited eye disease characterized by irreversible photoreceptor loss. And in summary, vision loss from inherited retinal disease is a debilitating condition. However, with many gene therapies available to ophthalmologists, there is hope for patients. And the main target for ocular gene therapy involves retinal pigment epithelium or photoreceptors. And the most common method to deliver viral vectors to these cells includes intravitreal subretinal injection of or access from the suprachoroidal space. And the recombinant adeno-associated virus can be engineered to maximize gene delivery to specific targets. And we have an Asian Eye Genetic Consortium, which was established in 2014 as an extension of the NIH, and it focuses on the eye research in Asia. And thank you very much for this. And next, I think, Jerry, you can invite the next speaker. They ready? Yeah, you have some comments?
No, next speaker I'm ready.
Okay, so next I invite Professor Kumaramanickavel. He is head of the research in research in vision and ophthalmology, and he's also one of the pioneers in working on ocular genetics from 1984, and I think he's worked maximum in RP also and many other diseases like Retinoblastoma, etc. And I request Professor Kumaramanickavel to give the next talk. In the meantime, when he's coming to the stage, any questions? But I have to shuttle between 3 halls. I'll be going and coming. And thanks, Jerry, for... you have any comments, Jerry? No comments? No, any comments? You have a microphone there.
My talk, which will follow, I'll be expanding on the genetic therapies, and you can see what is already present that's quite revolutionary and approved by the FDA, and what the problems are with other types of gene therapy and why we are not there yet. So stick around.
So good morning, everyone. Before I start, I would like to clarify something with the chairs. Dr. Natarajan? Dr. Natarajan? Sorry. Dr. Natarajan. So there are 2 speakers who have not come. Right. So do you stick to this time or do you have more time? Rajkumar. Jerry is last. So I'll take more time than what is 10 minutes. So thank you. So this talk has been prepared with my own experience of seeing 2 different types of patients with ocular genetic disorders. So genetic counseling is one of the most important aspects of patient management in ophthalmology. How do I? Okay. Now my talk is structured as follows. So I'll initially talk about the basics of genetics and then genetic counseling. After which I'll talk about 2 cases. One was referred as retinoblastoma and the second was referred as a child with autistic features and visual problems. And then I'll say that how we actually are managing today compared to what we have been doing ages ago, maybe a decade or two ago. Now, if you take any population anywhere in the world, you would have 4 different types of genetic disorders in a given population. And the first one is the chromosomal disorders, where you can have Down syndrome or retinoblastoma, where you can have a numerical defect or a structural defect. The second category is single gene disorders, say like cystic fibrosis or retinitis pigmentosa, sickle cell disease. These are the 2 kinds of patients that you handle in pediatric ophthalmology, because that's the place they all come to if they have vision problems. The third category is complex disorders, where you have like age-related cataract, diabetic retinopathy, and glaucoma. The fourth category is mitochondrial disorders, like Leber hereditary optic neuropathy, LHO, and other disorders. Now, in a clinic, when you sit in ophthalmic genetics, you would see predominantly single gene disorders, particularly my experiences with retinal degenerative disorders. Very rarely you would get chromosomal disorders, but Down syndrome patients could have cataract, for which they could come to ophthalmic clinic. Now, as far as genetic counseling is concerned, these 2 steps are very important. One, it has to be non-directive, and second, it has to be non-judgmental. So just because you have not married consanguineously, it doesn't mean that you can discourage somebody from getting married consanguineously. So your job is to give them all the information. It is for them to take the decision. Now, when you say non-directive, you're supposed to be listening quietly to what your patient is telling you. So the entire process of genetic counseling is based on nearly 75% of quiet listening to your patient. That relieves them quite a lot at the end of that process. And then you have to actually give them various options that are available. So you cannot give them just one option because you made a judgment, but you have to give multiple options that are available. I'll give you some of the examples as I go through some of my patients here. Now, these are very vital steps when you do genetic counseling. So one is that you make a diagnosis, very, very important. For example, if an ophthalmologist diagnoses a patient as RP and not as Usher syndrome, for various reasons, because it could be a mild deafness or it could be moderate deafness that might not be picked up. Some of these patients can easily lip read, which you might not be able to carefully see in a very busy clinic. So a simple RP can be inherited as autosomal dominant recessive or X-linked recessive, whereas Usher syndrome is always autosomal recessive. So there are many, many situations like this. A very clear-cut diagnosis is very important. And then, of course, communication is very important. If you know the language of the patient or the patient knows your language, then that is the best way you can actually do genetic counseling. Of course, you calculate risk and then give them options. And then you give them long-term patient support or government support that is available in a given country. Now, this is a process of genetic counseling. So you start with your genetic case, which has a clear diagnosis. Then you move on to get the pedigree information. Then you do a pre-test counseling where you are almost sure of the inheritance. And then if they are willing to do a genetic test, because in India, it's not covered by insurance. And in many parts of the world, including the US, many states does not cover genetic test in the regular insurance. So once the test is done, you can do a chromosomal test if it is, say, Down syndrome, or you can do a single gene test if it's retinoblastoma, or you do a panel of gene or a whole exome sequencing if it is, say, a retinal degeneration. There are nearly about 125 genes that causes some kind of retinal degenerative disease. So there's a huge panel that is necessary, in which all the exons of those 125 genes are stacked in a chip, and then they sequence it and tell you what is the mutation that is there. Now, nearly 70% or 60% of the times you can identify a mutation, but for various other reasons, sometimes you might end up back to square one. So once you have the result, you do a post-test counseling. Now the way pediatrics and particularly pediatric ophthalmology is being dealt with has changed as per this slide over here. So the traditional care pathway is where you see a patient, for example, with congenital cataract. The child is too young, and then you start to look at various other features. Both the clinical signs and symptoms are slowly evolving because as the child is growing. So you wait and watch and do preliminary investigations because you initially think it's a syndrome, so you do a chromosome test, and then you find new symptoms, signs coming up. Then you go one step after the other, and then at the end of 2 or 3 years, you come to a diagnosis. But this has changed. So the whole thing has gone upside down. So you start with a congenital cataract patient, you do a next-gen sequencing, for example, like an exome sequencing, and then you have a result. Then you have fairly, clinged on to a clinical diagnosis like a syndrome. Then you start to see for signs and symptoms in the patient. Okay, so that's the best way to manage, and it's being adopted in many parts of the world, particularly in the Western world, in pediatric ophthalmology. So this is a case of retinoblastoma. Usually they can have a large deletion like 13q14, where you can see it's a normal chromosome, and then this chromosome that's lost a bit of the 13q14 region, which is this region. It's a massive deletion which you can detect in a chromosomal study. But most of the deletions are very minor. So I will talk to you about one case with retinoblastoma, how we handled. So this is a minor deletion. So what this slide tells you is that you use a lot of single nucleotide polymorphism markers. It's a SNPs, which is a change of one letter that we can have in the region of the retinoblastoma gene. So in a simple way to explain that is that if you have a double dose, because you get one dose of RB1 gene from your father, another one from your mother. Okay, so we all have 2 doses of the retinoblastoma gene and the protein in each of the retinal cells. Now, if you look at this red line, that's a midline. So if you have a double dose, then you have, it crosses this red line. Whereas if you had got only one copy from one parent and didn't get the other copy from the other parent for a deletion reason, then it goes below this red line. Okay, so this is a microdeletion which you cannot see under a microscope. It can be done by a particular test called as the MLPA test, and somebody who wants to know about it, I can tell later on. Now this is a family which came to us, and you could see that that's the mother, this is the father, and they have 2 children. And this boy developed retinoblastoma, and this was the case of Dr. Mahesh Shanmugam in Bangalore. He referred this case to me. And you can see that when this child developed retinoblastoma and they underwent a surgery, this child was almost 2.5 years old, by which time this mother was pregnant with this child and delivered the child when this child underwent enucleation. Now therefore they have 2 children, and then the father came to me and said that he wanted another child. Okay, and he had 2 requests. One, he said that I want a child without retinoblastoma. And then second thing he said was that I wanted that to be a female child. Now, I clearly told him that we cannot gender type a child, both for ethical, moral, and legal reasons. And I told him that I'll certainly help to know whether this child will carry the retinoblastoma susceptibility or not. So he went ahead and then told me that he'll plan the family, but before that I said we have to do a genetic test. Now when we did the genetic test, we found that this child had actually got only one copy of retinoblastoma gene. The other copy was not present. Then I told him that we have to do a complete ophthalmic examination of all the members in the family and then a genetic test, for which the father agreed. And we went ahead with the test. So when we did the test, we found that this child and the father had double dose of RB1 gene, and you can all see that the mother had only one copy of the gene and she didn't have the other copy, and therefore this deleted copy is what she's given to this child. Okay, the normal copy is the child picked up from the father. Now, therefore, we said, I told Dr. Mahesh, but he already told me that the mother has a regress tumor. Okay, so I'm not an ophthalmologist, so you all can easily see that the tumor has regressed in the mother, and she was free of symptoms, and she never knew that she had any problem in the first place. Now, they planned the family, very, very cooperative, model patient actually. And then they planned the family, and she became pregnant, and we actually did the test. And all of you can now predict. Now, this child carries the defective gene or not? Yeah? Can you see that? Yes, so it got only one normal copy similar to this child from the father, and the other copy she got it from the mother, which was RB1 deletion. Okay. Now, therefore, I told the father that, look, this child has deletion and it is susceptible to get retinoblastoma. But I told him clearly that retinoblastoma is one of the easiest, very well managed patient where they can completely be free of all the consequences, and therefore you can even save the sight of the child and not only the life. But then he asked me one intelligent question, very smart. He's a space scientist, this man. And he asked me one question. There was a mild mental retardation in this child. This happens when you have large deletions in the gene regions, because it's not only one gene that is lost, but there are a few other genes in this region which will also be lost. Okay, and therefore mental retardation is a feature in these kind of situations, which was the case in this child. And I had literally about a dozen sittings with this family, okay, to do genetic counseling. And then I realized the mother also had a mild degree of mental retardation. Okay, whether she was quite in front of the husband or she had mental retardation was difficult, but later on I could realize that she also had some features of mental retardation. So the father asked me a question that whether this child will carry mental retardation or not. I said it's very difficult to answer, and I said that there is every chance for this child also to have a mental retardation. Okay, but I said that it could be as like the mother. Okay, she also has a deletion, and she wasn't having full-blown mental retardation like this child. But then finally they decided to go for an abortion. Okay, so that's the extent to which you can actually today do genetic counseling. Okay, very precise, very clear, totally non-ambiguous. Let me move on to another case that we dealt with, which is actually, if you see, I have put this case as, in my earlier slide, as autism and some vision problem. So this child was 7 years old, female child, and all these features were there right from birth, okay, and vision problems as well. And therefore it was diagnosed as autism and then managed for 7 years. Okay, can't believe this happened in the city of Madurai, which is very close to Coimbatore. And they've been running from pillar to post. So that's the family, okay, and this is the father, who was an ex-military man, okay, and the mother is a school teacher. Very, fairly informed, intelligent people, I would say. And that's a child. So they have another child, a male child, who's not there in this photograph. And we started to counsel this family. And to me, it looked like that it had some other genetic feature, some syndrome. Okay. The first thing I suspected was mucopolysaccharidosis. Okay. And then I referred this case to a psychiatrist, child psychiatrist, and then she looked at it and then said that it's not a typical autistic feature, but then she also thought it could be mucopolysaccharidosis. So then we did a MPS gene panel test. Mucopolysaccharidosis, there are quite a lot of them. I'll show you another slide where I can show the list. And that's the pedigree, consanguineous marriage. Okay, it's a first cousin marriage, and you can see the first child, the girl affected, that's a boy that I said that is apparently normal. Okay, and I was told that this child was developing some features of MPS, but they're not sure. Okay. Now, when we did the MPS panel sequencing, okay, we found a gene which was SGSH. Okay, it's a very important gene. In exome 5, there was a mutation, and it was homozygous. Okay, which means both copies came from each one of the parent who had two recessive copies with them. They had one normal copy, so they are always normal. And the two wrong copies were passed to this child. Okay, and therefore she got that as two copies of homozygous mutation and had a particular type of MPS called 3A. Okay, so this is the power of doing a gene panel today and making a diagnosis. So we went into literature, found that they have multiple features, including they can develop blindness. Okay, the real fault is that the heparin sulfate that is produced in the body is not digested by this enzyme, and therefore it starts to get deposited in all parts of the body and creates all kinds of problems. When it deposited in the brain, you have behavioral disorders, and then they can have all kinds of problems, as you can see, including the vision problem. Now, when we went and found in the literature, we found that a particular type of soybean derivative, okay, is actually available, but it's more preventive. Okay, it's supposed to be not very clear how this is acting in mechanism. There are some clinical trials. These clinical trials are very conflicting. Okay, you have good results in one study and not that effective in the other study, and so on and so forth, because to get a population of MPS patients, and then particularly this 3A type or Sanfilippo type, and then give this trial and find out if it's working, is quite a difficult study in the first place to do. Now, you can actually give the substitution of the enzyme, okay, and try to see the effect of it, but all that they are trying today in clinical trial research. So as far as MPS is concerned, there are many types. Okay, the type that we had was this MPS Sanfilippo type A, okay, with heparin sulfatase enzyme deficiency, and therefore you have heparin sulfate that accumulates all over the body. Now, the sad story in this is that last week this child had developed quite a lot of complications. Respiratory infection, poor immune system is one of the most one of the hallmark of MPS 3A or Sanfilippo. And this child went to ICU. It was completely mismanaged because I spoke to the pediatrician in Madurai, and then he wasn't aware of this MPS. And I had to tell him. It was very difficult to contact them and talk to them. I informed them. And you have to be very careful what drug you use, because the liver also doesn't function appropriately. So any anesthetic, even a cough syrup sedative, can cause quite a big effect on them in terms of drowsiness. Okay, so if this test had been done at the time of birth for the child by a pediatrician, they could have handled this case much better. But generally, they don't live beyond 20 years. Okay, she died last week at the age of 7. Okay, so with that, today this is how the field is sitting. Ophthalmic genetics. So in situation 1, say for example like Stargardt disease, you diagnose, there is clarity, non-ambiguity in diagnosis. Then you do NGS sequencing, and then you know what is the mutation. Okay, so both are positive, non-ambiguous. Now you come to situation 2, which is what most of the times most of the pediatric ophthalmologists would face, is that you're not very clear about the diagnosis, but you do a NGS sequencing, and then you know what is a mutation, then you look for features. Okay, that's situation 2. In situation 3, you're not sure, it's an ambiguous diagnosis, and you do an NGS sequencing, but you're back to square 1. Okay, this could be not only because that the disease is evolving, but because you have to have another member in the family with the same disease, and you can easily validate. Okay, do the same gene test, and you can find out the mutation. Or some of the genes that have not been identified as of today, causing some of the retinal degenerative disease, could be the reason why you cannot actually find out what is the mutation. Okay, so these are the 3 situations that currently all over the world people are facing when they manage patients with various genetic eye disorders. So therefore, I'm coming back to this situation. So this is the way currently people handle, which is much more medically and legally correct to do. This test is expensive. Somebody wants to know the cost of it. I will be able to say it if you want to know later on. Okay, so let me come to the summary of my talk. So I gave a brief about basics, and then I spoke about the application of genetic counseling and how we handled it in two different cases, one with retinoblastoma, other one with Sanfilippo syndrome. Okay, and I spoke about the current scenario, that how you actually do an upside down clinical practice as unlike a traditional way. Thank you.
Okay, I'll ask if anyone has any questions, but the one thing I know is that if we have any inherited genetic family problems, we know where to send these people to.
Okay, thank you. Yeah, there's someone.
A very nice talk, thought-provoking, and for someone as a pure clinician like me, who we don't really get these tests done so often. Especially, I wanted to ask you about the retinoblastoma case that you showed.
Yeah.
So, like we know that by Knutson's two-hit hypothesis, you have to have both the copies wrong.
Correct.
But what I understood from your talk, the first child had just one copy wrong, and he still had the disease.
Correct.
And the third fetus, you found again one copy wrong.
Correct.
So still, how can you predict that the second would also go wrong, and what is the chance that the third fetus, what percentage chance is that he would develop retinoblastoma?
Okay, that's a very good question. What Knudsen said is right. Okay, so the germline mutation is the first hit. Now, when the child is born and then the retina is developing, these retinal cells multiply so fast. Okay, and in the somatic tissue there is a mechanism, okay, called as loss of heterozygosity. So you have two copies of this retinoblastoma gene in each of the retinal cells that you have. So one is defective, okay, so it's a completely deleted copy, and then you have one copy that is normal. Now, in loss of heterozygosity, what happens is, because of the cells are dividing, and then all the chromosomes go to each of the poles, okay. Now, by this loss of heterozygosity mechanism, this right copy will go to the other retinoblastoma cell, and you'll have two wrong copies in one of the cell, okay, and that retinoblastoma, that retinal cell divides and becomes retinoblastoma. Okay, so after retinoblastoma gene was discovered, there are 35 different types of tumor suppressor genes that have been identified. Some of the diseases that you can have is like breast cancer, neurofibromatosis, all are similar mechanisms. The second copy loss happens because of the loss of heterozygosity mechanism. So it happens in a highly dividing cell. Okay, so therefore, if you go to the somatic tissue and then you see which people have done with tumor samples, they would have only one copy. Okay, so therefore you can predict. Again, it's susceptibility. All right. So I told the father that the child could be like mother, completely free of the disease with the retinoma. Okay, but then it's the parents who decided to go for the abortion. Yeah. Yes, sir. Vinay.
Genetic counseling is actually so complex because even for single gene, I can understand the chromosomal disorders, but for single gene disorders, there is what we need to know about the penetrance and expression of the genes. You know, you could have a mutation in a family, and you're not very sure about the expression and the penetrance. I mean, how do you genetically counsel? Such conditions is my first question.
Yeah. See, there is one catch in ophthalmic genetics. Okay. Say, for example, when parents want to go for abortion, as medical personnel with ethical and moral standards that we have, any disease which is lethal, okay, if they go for abortion, the parents decide to go for abortion, then you're okay. For example, retinoblastoma in some terms is lethal gene. But then, if you take Stargardt's disease or retinitis pigmentosa, I mean, it's not lethal. I mean, you can live your full life with Stargardt's disease. You can have fairly, mobility, vision. or you might not even have that. But that's not lethal, and you're not going to die because you have Stargardt disease or retinitis pigmentosa. So when patients ask you for a question like, should I actually abort this child, you leave it to their judgment. But coming to your question, looking at penetrance, some of the autosomal dominant disease could have low penetrance. Okay, so your job is to tell them, and you can always explain many situations. I've clearly explained this is the limitation, okay, and this is the knowledge, and this is the information, and you leave it to them to take the decision. So your job is to give all information, and it is their job to finally take the decision. That way, if you do that, that's how I've been doing it. Most people do it the same way across the world.
My second question was, are there any certificate courses for genetic counseling, maybe not for ocular genetics, but for
There
genetic
is,
counseling in
actually
India?
there is, it's available online, you can do it, and there are a few hodgepodge areas in India where people do it, mostly run by non-medical groups, okay, and therefore MCA does not recognize that. So if you're looking at a certification where you actually need it for your own career, doing it online, I would say, is better. There are some of the American, I can give you those links. At the end of it, you'll get a certificate, but then you pay some money for it. Whether, where you work, people would recognize that and give you some kind of a career advance like promotion is not still clear, but you can certainly do such courses.
Okay,
Yes.
I think that we have to go on with our speakers.
Okay.
We'll save additional questions for the end of the session, depending upon how much time we have. The next speaker.
Thank you.
Okay. The next speaker is Dr. Rajkumar. Dr. Rajkumar is the Director of Genetic Research at the Ajat Eye Hospital in Mumbai. Dr. Rajkumar.
Thank you, Dr. Gerald. Good morning, everyone. And I thank AIOC for providing this opportunity to present a few of my work. So today I will be talking about the application of next generation sequencing in identification of candidate genes of some ocular congenital anomalies. In this case, I have taken persistent fetal vasculature as my study sample. And the whole discussion will be on how the whole exome sequencing has helped us in identifying candidate genes for persistent fetal vasculature. And I will be talking about certain tools that are helpful for identifying deleterious variations that are present in some cases. So this persistent fetal vasculature is a congenital ocular anomaly that normally develops, leads to developmental blinding diseases and often present in preterm infants with low birth weight and also affects in 1 in 15,000 live birth. In general, during embryonic development, the lens is supplied with an enormous number of blood vasculature for supplying oxygen as well as nourishment to the growing lens. But at the time of birth, this vasculature has to regress. In some cases, it is not. Why? There are a lot of mechanisms behind it, and that condition leads to persistent fetal vasculature. And in this picture, this is a typical PFV, where the B scan shows there is the existence of vasculature between retina and lens, and in control, there is none. So, based on this information and based on the available literatures, we found there are a lot of congenital, candidate genes are available, but none found to be very strong. And there are several mechanisms have been identified using in vitro and in vivo models, but still there is no satisfactory results, and the results are conflicting. So therefore, in the present study, we wanted to screen for novel candidate genes as well as mutations and SNPs that are associated with persistent fetal vasculature using next generation sequencing platform. Why we have opted for next generation sequencing platform is that when comparing to the conventional Sanger sequencing, which is a normally routinely doing methodology, for identifying mutations or genetic variations in the gene. This method, this platform is a modern and high throughput DNA sequencing technologies, wherein more number of samples can be done parallelly and in a very rapid rate. And when compared to the cost between the Sanger sequencing and this next generation sequencing, it is very, very cost effective. And within the same amount of cost what you are using in Sanger sequencing, the same thing can be performed with next generation sequencing. And moreover, it saves lot of time and it has a very simple workflow. Because of that, there is very less error rate. And moreover, it gives you lot of data, both qualitatively and quantitatively. And the read length is very high. It means that the coverage of the genome is very high. And moreover, it has wide range of applications. It means that we can sequence the entire genome of bacteria to the human sample. So this next generation sequencing that performs with two different molecules called deoxyribonucleic acid and ribonucleic acid. And using DNA, we can go for whole genome sequencing. And with in that case, we can sequence the entire genome. Whereas in whole exome sequencing, we can sequence around 2% of the entire genome. And other panels are available in that certain genes can be sequenced using targeted exome sequencing. With RNA, we can go for the whole RNA transcriptome sequencing. So there are several players and manufacturers are available for these next generation sequencing platforms, and some of the examples that I have given here. And there are several models are available in the market. How this next generation sequencing works, where it starts and where it ends, that is very important. And in this case, any of the sample, DNA or RNA, will be fragmented into minute fragments of a certain size that will be further used for the library preparation, wherein the DNA or RNA molecule will be tagged with an adapter. It is a kind of barcode. Then that molecules will be sequenced using next generation sequencing platform, that is sequencing by synthesis. So the same copy of that fragment will be synthesized again to sequence it. Then based on the huge synthesis and sequencing reads, so the bioinformatics tools will come into play. So the fragmented region after sequencing will be arranged in a tandem and it will be made into a contigs. So based on that contig will be referred to the reference genome sequence. So this is a general workflow of the bioinformatics. So the raw data will be aligned to the genome of interest, and this will undergo two different processing called BAM-SAM and GATK processing, wherein the variations will be annotated properly. And that variance will be filtered and will be exported to the file. So where to get all the genome sequences? So there are a lot of browsers available, and the most three important are Ensemble Genome Browser, UCSC, and NCBA Genome Browser, to which we can compare our sequencing data. So for this present study, so we recruited the subjects upon a thorough ophthalmic examination, and we considered the cases, those who are having congenital cataract with symptoms of PFV, and we took controls, those who doesn't have PFV, even with the presence of congenital cataract. And about 2 to 5 ml of peripheral blood have been collected, and DNA was isolated using the standard methods. And about 3 cases of PFV and 4 cases of controls have been subjected to whole exome sequencing analysis and followed by the sequencing. So the particular variations have been analyzed for its functionality using mutation tester and other tools, and the candidate genes have been analyzed using candidate gene prioritization tools using Endeavor and TopGene. These are the 2 major candidate gene prioritization tools available in the online. So the results are interpreted accordingly. So This is a summary of the whole exome sequencing data analysis. And what we got, the raw data, if you see, for the case 1, 2, and 3, it is a huge, around 6 GB of data that we got. So out of that 6 GB of data, the total past single nucleated variations were around 10,000. So in that 10,000, we selected only non-synonymous variation. It means that is going to change the amino acid sequence of a protein. So we selected around 100 such, 10,000 non-SNVs in all cases based on the homozygosity. So we had selected around 10,000 non-synonymous variations based on the homozygosity condition, and we further filtered off for the PFV. So what we did, whenever the homozygous variants are common to all the PFV cases, which is not present in cases were selected. So likewise, we filtered off around 100 genes that were harboring pathogenic mutations in only PFV cases, which is not present in control. So for that particular variants, we did functionality testing using online tools. And these are the different functionality testing tools that are available in online: Polyfen, then Shift, Praveen, Mutation Tester, and Assessor. Each and every algorithm will have different calculations for the severity. So that calculates the severity of the variation and gives the result as probably damaging, deleterious, or disease causing, and a high damaging. So based on that, we classified the genes and variations that are having high pathogenicity. And so based on these results, so there are around 18 different genes that harbors highly pathogenic mutations or variations that are common to all PFV cases. So the black one is the homozygous condition, and the blue one are the heterozygous condition, whereas the gray one are wild type, which are not there in the controls. It means the variation is not there in the controls. And some of the variations are unique to that PFV cases, which is not present in other cases as well as in controls. So likewise, we selected around 19 different genes that harbors deleterious variations. And when we subjected these 37 genes for the candidate gene prioritization using these tools, Endeavors and Top Gene, so we got around 13 genes to be involved in vascular remodeling or abnormal angiogenesis. So these are the 13 different genes that were involved in vascular remodeling, and out of that we selected the 4 genes ERAP1, GDF3, HLA-A, and MAPT, because the literature states that these 4 genes are somehow directly or indirectly involved in the angiogenesis process. And this ERAP1, that is endoplasmic reticulum aminopeptidase 1, that are responsible for processing the antigen present antigens, so by cleaving the C-terminal ends. So this is involved in postnatal neoangiogenesis, as well as this particular variation, that RS30187, which is a SNP. So that is found to be associated with the regression of left ventricular hypertrophy, the other disease. So we felt that, or we believe that this ERAP1 might be associated with vascular remodeling diseases like PFV and other retinal vasculature diseases in association with other such genes. This work was presented in the last IARG conference. Thank you.
Well, thank you very much. That was quite an elucidating talk. What we're going to do is hold the questions until the final talk is given, which is mine.
So next we have Dr. Schultz, who is an associate professor of ophthalmology at the Loma Linda University Medical Center, California, and also the director of the ophthalmic services at the Desert Regional Medical Center, and the Regional Trauma Center. And incidentally, Dr. Schultz has been attending AIS since 1981. So that's a long record, Jerry.
Well, thank you very much. Although I've been to India many times, this is the first time I've been to Coimbatore, and I appreciate the hospitality and the immense amount of work that the organizing committees have done. To be greeted by elephants and a band as you walk into a meeting, this outdoes anything I've ever seen in any meeting, in any conference worldwide. What I'm going to do is review ophthalmic gene therapy, and I'm going to bring you up to date. Some of this has already been reviewed and discussed by Dr. Natarajan, so please forgive me if there is some duplication. I have to give you a disclosure. I do not have any financial interest in any of the manufacture of genes. Right now, medical therapy is at the level that computer engineering was back in the 1950s, 1960s. There was a lot of work that's being done in medical progress, in pharmaceuticals to treat bacterial, viral, fungal infections, to treat various disorders, inborn disorders. We're at that level right now where we just have some drugs, they're blanket type drugs. In many ways they work, in many ways they don't, but they're not specific for the individual. So right now, we're inefficient, just like the old IBM computers. They were good for their day, but compared to what we have now, they're quite inefficient. When the silicone chip came out, it revolutionized the computer industry, our ability to mine data and to have it easy at our fingertips, either with a laptop or even the cell phone. That's our little portable computer that probably gives us as much information in a small package that that whole room full of computers and personnel had back in the 1950s and 1960s. So what took place? What is taking place right now? CRISPR. CRISPR is the future. Does anyone know what CRISPR is? Well, you're going to find out now. CRISPR is the clustered regular interspace short palindromic repeats. Now, what the hell is that? Well, a palindromic repeat is a double-stranded sequence of DNA in which the order of nucleotides is the same on each strand, but they run in opposite directions. So this is going to be the basis of future genetic therapy. Now, each repetition is followed by a short segment of spaced DNA, a plasmid or a virus. We'll go into that later. On top of that, we have the Cas, CRISPR-associated system. It's right next to the CRISPR sequences. What are these? They are molecular scissors to cut or repair the DNA. Now, we have a special version that can edit the genome. It enters a cell together with a synthetic guide using GPS, well, RNA. It cuts the cell's genome at the desired location, and therefore you could have designated genes removed and new ones added. We want to remove the bad ones and replace it with the good genes. So, CRISPR will create double-stranded breaks in the DNA at the specific points. This is new. This is revolutionary because some of the designs before were very inefficient. They were very expensive, like the zinc finger nucleases, which you probably heard of, zinc finger. the talons, transcription-activated effector nucleases. These required a custom protein for each targeted DNA sequence. It was clumsy, it was time-consuming, and expensive. Well, a CRISPR requires manufacture of only a short RNA sequence. Now, how is it used? Well, biomedicine, that's us. For research purposes, we could create mutations in the human pluripotent stem cell to grow the diseased organoids so that we could study them. We need to have something on the petri dish so that we could study it. That's what it could do. It could give you novel antimicrobial therapy. It could target genes in bacteria that could encode the resistance to some antibiotics. We know about MRSA, and that's another issue, another subject about the genetics of MRSA in the bacteria. We know about other resistance in bacteria. Vancomycin is becoming bacteria getting resistant to that. We can now individualize cancer treatments by repairing muted cancer-causing genes. At least that's what we want to do. We're not there yet. And of course, as I mentioned, we could delete a gene that could interfere with the immune system's ability to fight cancer. This is what's coming. We're not there yet. Okay, now the controversy, germ-line modification. Can we now work on embryos if we see there's a deficiency genetically in an embryo to replace it, correct those mutations before birth? Well, we could also create new species, bright people, or people that could become future ophthalmologists in all the generations. That's social Darwinism in a genetic modification. So how does this work? Change the DNA software and change the species. That was Craig Venter, who's in San Diego and has been doing this with various types of microorganisms. So what are the digitals for us? Purines, the adenine and guanine, and the pyrimidines, thymine, and cytosine. These are the 4 bases of all life. You change the sequence, you replace any defective gene with this. It's a computer. You can do it. And here we are, converting the analog genetic code into a digital code, right here. Now, in molecular therapeutics, we have 2 different paths. We've got the genome sequencing and tissue engineering with stem cells. You can read it up here. You can see what it is. Our topic today will concentrate on genome sequencing and identification of the mutant gene, and also DNA gene replacement. Of course, the most famous genetic disorder that we've been talking about is the RP65 retinal dystrophies. Now, these are biallelic RPA mutations associated retinal dystrophies, in which you have mutations of both copies of the RPA gene, and it's diagnosed with genetic testing. The next generation sequencing, here's a laboratory that does it. You can see what it's like. It's fairly inexpensive to run now. They could read 300 billion bases per run. This is the next generation sequencing that was previously alluded to. So let's take a look at the different RPE65 retinal dystrophies. I did highlight Leber congenital amaurosis for a certain reason and retinitis pigmentosa at the top. This was previously discussed. I'll discuss it further. We also have severe early childhood onset retinal dystrophy, or CCORD, early onset retinal dystrophy, and early childhood retinitis pigmentosa. Okay, so for those that are not totally familiar with it, we know that these dystrophies, the signs and symptoms of night blindness, usually occur before 95. You get nystagmus, prolonged dark adaptation, diminished visual fields, and severely reduced to undetectable ERGs. Aha! Can we cure this? Can we treat it? Luxturna. Luxturna for Retigene Naparvarak was approved 2 months ago by the FDA. It's an AAV2 vector that has the RPE65C DNA. This was alluded to by Dr. Natarajan in his opening lecture. This was developed by Spark Pharmaceuticals and Children's Hospital of Philadelphia and approved just 2 months ago for Leber congenital amaurosis and retinitis pigmentosa. For this, the patients must have viable retinal cells. Here is the vial. Wow, look at the price tag. $850,000. I won't ask you how many lakhs that is. Now, it's broken into 2 parts. It's just one treatment. It's a one-time treatment. Each eye will get an injection, and that would be $425,000 for each eye. Now, no one can really afford it unless it's a billionaire. It's what we call an orphan drug. But there will be financial manipulations with the manufacturer, with insurance and everything, that will reduce the cost to the family of that individual. But this is what it is. It's diluted, injected in the eye, goodbye. You're cured. Well, that would be nice. It's based on the intravitreal AAV stereotype 2. Dr. Natarajan talked about some of the others, like 8 being developed also for retinal disease, but right now we're at 2. Let's go into gene therapy. These are vectors, usually viruses, that have been genetically altered to carry the normal human DNA to deliver a therapeutic gene to the target cells. And as I mentioned, scientists are manipulating this genome to remove the disease-causing genes and insert new ones. And this is a sequence of it going into the body, gene therapy using an adenovirus vector. Okay. You could give it intravitreal, but there are problems with intravitreal. It doesn't really penetrate the internal limiting membrane of the retina, and you only get about a 10% success intravitreal. What about subretinal? If you give it subfoveal or in the retina, you run the risk of getting retinal atrophy. So instead of improving it, you're hurting it. So what is needed is a type of carrier that could be given both intravitreal and penetrate the internal limiting membrane, given in the periphery so that it's absorbed into the retina without causing atrophy of the critical sites. That's what's being worked on, and this is in the periphery. And here's the mechanism. We have the little DNA genome. It's caught by the capture areas of the cell membrane. It penetrates into that in a little carrier, and then it will transduce into the nucleus. But to have a change now, you have to have 2 different DNAs to work. We're trying to work it with just 1 DNA, but right now it's 2. And then your new protein is manufactured. That's for the retina. Let's talk about glaucoma. Glaucoma still is a problem. This is what's been worked on. Different types of vectors to penetrate the trabecular meshwork so that the aqueous could get to the collector channels. What are the problems? We're not there yet. Let's look at the problems. Here's the potential vectors. I showed you the vectors, but here they are. The non-viral, this is just an outline. The naked DNA plasmid, interfering RNA, and the chemicals. We'll go into this. And then we have the viral, the herpes simplex, the adenovirus, adeno-associated viruses. This is one that's really working, the AAV. please understand there's a difference between the adeno-associated and the adenovirus. And finally, the lentiviruses. I'll go into this in a little bit more detail. Let's go into the non-virals. I mentioned the naked ones or plasmids. Very temporary effect because the DNA is not integrated into the host chromosome. Then we have the interfering RNA. Now, this could silence the expression of deleterious genes of a known sequence. And we have the short interfering RNAs. And the testing shows that it could inhibit targeted genes, myelin, the myoc, that we see in glaucoma. And we have the chemical, the liposomes, that could transfer genes just in cell culture. We're not there yet. The virals, I did mention the adenovirus. These are intermediate-sized, non-enveloped DNA viruses, so it's easy to express. It can get into all types of cell nuclei. What are the problems? Severe inflammations. And we get high neutralizing antibody titers that could limit its effect. We have the herpes simplex, large enveloped DNA. These have envelopes around it. And they could go into the trabecular meshwork, the ciliary body nuclei. It's transduced. Problems, inflammatory responses, cytotoxicity, and a limited effect. Let's go to the virals. The adeno-associated viruses. Okay. We have both the replication deficient virus that may or may not require a helper of an adenovirus. It gets into the host genome. It's transduced. What are the advantage? We don't have any